Hello friends, welcome to Creative Medicine. In this lecture, we will learn about.
Hello friends, let us now learn about the treatment of Cushing syndrome. So, if you see the treatment of Cushing syndrome, so first this treatment depends upon the type of Cushing syndrome. Okay, whether it is ACTH dependent or whether it is ACTH independent Cushing's syndrome. Now, if you see the Cushing's disease, that is, if in Cushing's disease there is pituitary adenoma which is producing, in the pituitary gland there is adenoma. This adenoma is producing ACTH which will activate the adrenal gland, resulting in production of cortisol or glucocorticoids, which causes Cushing's syndrome or Cushing's disease. This condition of pituitary adenoma resulting in Cushing syndrome is called as Cushing's disease. Here you will have to remove this adenoma. So you will have to here the treatment is removal of this adenoma with transsphenoidal approach. With transsphenoidal approach, you will have to remove the pituitary adenoma. But sometimes there can be the chances of recurrence of this adenoma. If recurrence of this adenoma occurs, then you can either do a second surgery or you can do radiotherapy, or you can also do a stereotactic radiosurgery can be done in these patients with pituitary adenoma resulting in Cushing's disease. Then, if there is ectopic ACTH syndrome, in this ectopic ACTH syndrome, where the tumors of our body like small cell carcinoma of lung or medullary thyroid carcinoma or carcinoid tumor of lung, all of them will produce the ACTH. And pheochromocytoma will produce ACTH, resulting in Cushing's syndrome. So in this ectopic ACTH syndrome, you will have to treat the primary tumor. Once you treat the primary tumor, the paraneoplastic syndrome will obviously suppress, resulting in treatment of the disease. Then if you see for adrenal gland, if whenever the Cushing syndrome is ACTH independent and if it is due to the adrenal issues like adrenal adenoma or adrenal carcinoma, then you will have to definitely do a surgical excision should be done. Right? Next, if it is due to adrenal adenoma, we have something called as adrenal enzyme inhibitors. These are used only if there is adrenal adenoma. We can use these adrenal enzyme inhibitors, which are ketoconazole and IV etomidate, can be used if there is this adrenal adenoma. We also have some adrenolytic agents. The adrenolytic agents like mitotane can also be used in these conditions. Right? What does this adrenolytic agent mitotane is actually a derivative of insecticide. Okay, so this surgical resection of adrenal adenoma or adrenal carcinoma is adrenalectomy is done. Right. Preoperatively, in this adrenalectomy, before we do adrenalectomy, preoperatively we will have to manage the patient by giving prophylactic anticoagulants and antibiotics. Anticoagulants and antibiotics are given because Cushing syndrome will predispose to increased infections. So to counteract infections, preoperatively we should give antibiotics, and Cushing syndrome is a hypercoagulable state. Because it is a hypercoagulable state, it will increase the risk of deep vein thrombosis and pulmonary embolism, which are very serious disorders, especially when a patient is going to be taken for a surgery. So, in order to prevent deep vein thrombosis or pulmonary embolism, we should give prophylactic anticoagulant therapy pre-operatively. Then, after surgical resection, remember, we are removing the adrenal gland. So, obviously, we do not have the cortisol. If you remember, the stress gland of our body is adrenal, and the stress hormones in our body are produced by adrenal medulla and also adrenal cortex. Like the stress hormone, mainly the cortisol, is produced by the adrenal cortex, and important hormones like adrenaline are produced by adrenal medulla. So we will have to give supplementations post-operatively. So post-operatively, you will have to supplement mainly the cortisol. Immediately within first 12 hours, we can give 15 milligrams per hour can be given parenterally or IV for first 12 hours, and after that you can give 100 milligrams for 3 days, and then you can decrease or taper the dosage. Right? If you do unilateral adrenalectomy, it's very fine. Unilateral adrenalectomy, then you do not need to do any replacement therapy, is not necessary, because obviously the other adrenal gland which is present in our body will work, and it can produce the required hormones by our body, required enzymes and hormones by our body. But if we do bilateral adrenalectomy, then we should give hormone replacement therapy is necessary if we do bilateral adrenalectomy. Then fine, right? Sometimes there is a side effect of this adrenalectomy. You have done a bilateral adrenalectomy in a patient, and that patient actually has a pituitary adenoma which has been missed during the diagnosis. He had adrenal tumor, and for that you have done bilateral adrenalectomy and you have missed pituitary adenoma. Because we have missed the pituitary adenoma, now because of this adrenalectomy, this pituitary adenoma will become more aggressive, and it will become an aggressive tumor resulting in symptoms, and this is called as Nelson syndrome. Right? So this is about the treatment of Cushing syndrome. Thank you guys for watching my lecture. Thank you.
Thank you, and thank you for watching.